Afternoon, folks. Here's another episode of job planning. This time, this is mainly going to be my comments on the job planning presentation that Manx Care had done, and most of you would have watched. Starting with first slide, point number one: medically led, good, but it should also be medically conducted or delivered and management facilitated. Essentially, your job plan review meeting should occur between you and your medical manager, not every Tom, Dick, and Harry and their cousin. A manager, general manager, may be present with your consent. I would definitely recommend that. In my experience, presence of general manager has been helpful. Point two, good. Three, good. But transparency should apply across the board. Next point is also important, and it's an important variation from NHS England contracts. I do quibble with the next point though. A needs analysis and some capacity work needs to be done to determine the service delivery plans for your division or care group or whatever. And then team service delivery planning should occur. The common misnomer being team job planning. It's actually team service delivery plan. And then the individual job plans come. Good. And objectives align with Manx Care's mandate and operating plan. That's fine. Point one, it should really read typical job plan should have 7.5 direct clinical care and 2.5 supporting professional activities. And coming down below, 1.5, they're more like core supporting professional activities. Those are all the activities that you really require in order to satisfactorily fulfill your appraisals and stay revalidated. And in addition to that, a typical consultant should have one more SPA for all these activities, but also just to have time to interact and engage with colleagues, other professionals, managers, or to even read the hundreds of management emails that we appear to get. The next point I do not accept unless they want you as a practicing doctor to be completely disengaged and not to contribute to any service improvement, etc., etc. 1.5 SPA is not sufficient. We want an engaged medical workforce who work together, pull together to optimize the services we deliver to our patients. And without appropriate time allocation, that is not possible. Additional programmed activity, can't quibble with that. Additional leadership responsibilities should be termed ARs in the job planning process. But other than that, that's fairly straightforward. This slide, I must say, I'm quite disappointed because this appears quite insulting to me. As somebody who finished schooling well before the end of the last millennium, To say that my current job plan is like a school timetable, I find that quite insulting. Maybe it's just my age, but no, I don't think that is right. Most inpatient specialties work best with regular timetable activities. No, not the acute specialties. What are we talking about? I accept some specialties work best with the regular timetable of activities. And even within the specialties, there are variations. For example, if we take a look at orthopedics and traumatology, orthopedics will probably work well with the regular timetable of activities, but I don't think traumatology does. Anyway, that's enough of a rant. On-call rotas will be specialty specific. That's good. No point calling me for a geriatric emergency or urology emergency. I won't have a clue. Some specialties work well with annual job planning. Okay, possibly. I'm interested that we've chosen the areas with probably the highest bank and agency spend in the last several years. But if that's a perception, so be it. Objectives, yes, should be measurable. Yeah, it should really be SMART. You all know what SMART stands for. These can include number of patients seen in OPD, number of operations carried out, reduction in waiting list, achievement of specific supporting activities. Well, because it says these can include, but you know what? This should be included in the job plans of every single clinical director, because you can't include these in the job plans of individual doctors who are not in any leadership or management position. Number of patients seen in OPD. How can you control that? Will you be penalized for DNAs? Will you be penalized if clinics gets cancelled? Will you be penalized if we don't have the adequate support staff? Same for operations. Theatre lists get cancelled all the time, often because we've cut the total number of inpatient beds, so they get filled up and we don't have a bed for the operated patient to go to. They get cancelled for no reason sometimes, and I believe they started cancelling when you're on annual leave, etc. So yes, these can include objectives. The objectives can include these, but only in the job plans of those colleagues with leadership responsibilities. Please don't accept these type of objectives which you don't have any control over without talking to us. They should include some element of waiting list validation with agreement, yes. Not without agreement. They should include some element of advice and guidance with agreement. I think certain areas have already started that. Okay, PA, programmed activity. Normally 1 PA equals 4 hours of work and 3 hours of work premium time. Yeah, that's straightforward. Well, that is not so straightforward. In general, 1 clinic equals 1 PA, but that is if you have a perfect EPR system, for example, where you only have to open one window, all the relevant patient information is available to you. You click on one link and all the patients' imaging is available to you. But with our real clunky system, by the time most mornings to boot up your computer, and open the 5 or 6 windows and programs that I need to open in order to see one patient. That alone takes about 20 minutes. So the contract says one programmed activity is 4 hours of work. It doesn't really specify how many patients you see, etc. And this is a very time-sensitive contract. And the time you take for a procedure is the time you actually take. It's as simple as that. And very frequently in many specialities, each patient seen generates further activity that is clinical administration. You get queries from patients, parents. You need to discuss with colleagues, request imaging, request other investigations, look at them, formulate a plan, and then communicate. So these are broad guidelines. You should probably, like for example in pediatrics, for simple patients, i.e. your cough, cold, simple asthma, etc., the recommendation the Royal College gives is half a programmed activity per one programmed activity of clinic. But for complex pediatric patients, the ones who would usually be all seen in the community pediatric clinics, they recommend one clinical admin session per one clinic or DCC. So I do agree with the next point, which is that you really need to determine average times required by consensus with specialist guidance if available. Operating sessions, this is probably okay. I'm not a surgeon or an anesthetist, so I can't comment on that. But at the end of the day, it's the time you take. Simple as that. Yeah, post-trach orthopedic ward run may take 10 minutes. Goodness. Okay, again, not my area of expertise. I won't comment. But at the end of the day, it's the time you actually take. P allocations will be determined collaboratively, and if there's any doubt, by diary exercise. That's the but should be standardized within the same specialties. I seriously doubt that's possible, but if every specialist agrees, then why not? Other DCC reporting sessions, again, the key is in collaboration. You can't really go by college guidelines for workload because, as I always say, guidelines are for guidance of the wise and blind obedience of fools, and we are all wise professionals. And similarly, we're not comparing like for like, because college guidelines for, say, Guy's and St. Thomas's would probably talk about one consultant assisted by 2 nurse specialists, 3 CNSs, 2 registrars, and 5 SSUs conducting one clinic. That's not the same as a single dog's buddy who has to do everything in a clinic. So yes, they can be taken for guidance, but agreed locally. That's not standard, it's minimum, absolute minimum. No, it's not in general. It is a whole myriad of activities, starting with even reading management emails. Because if someone's only allocated 1.5 SPA, then quite legitimately say, I'm not going to interact with any of my colleagues, nor the nursing staff, nor other professionals, and I will not read any management emails. And you'll be well within your right to say, do that. At the same time, it's not just a 2.5 SPA that's a gift. You really need to account for it. So from that, if preferred a standard job, that's a very bad job, I would say. Uh, if we reach such a stage, um, especially when we're trying to improve the culture and the clinical engagement, that will be a very sad day. Okay, that's interesting comment. Otherwise, why would anyone take them on? I'm probably old-fashioned. I would take them on to make things better for my patients, not because I get a big wodge of cash and enhanced pensions. Yeah, that's fair enough. Duties should be divided up equally amongst those on the rota? Not necessarily. Um, there should be choice. I know not long ago, some consultants were on a different rota frequency in the medical rota to others. I don't see a problem with that if that's what they would prefer to do and adjust their job plans accordingly. I don't see a problem with that if all colleagues agree, of course. Yeah, that's fine. Well, this is not a contractual requirement, but most colleagues will agree that you need to be reasonably accessible. Okay. This part is correct. However, there's absolutely no obligation in the contract for you to undertake any non-emergency work in either premium time or weekends. You may choose to do a ward round in agreement. However, you're under no obligation to do so. If you've agreed to be on call, you're on call, you will come in if called. If you're then expected to conduct ward rounds every Saturday or every Sunday, you can be requested, but as I said, only if you agree will you be asked to, will you be expected to undertake regular scheduled work such as ward rounds, virtual fracture clinic, eye clinic, etc. That's all. You have the right to say no. Yeah, true. Yeah, hard to argue with point one. Point two, no, that should not be expected wherever possible. You do have uh, what we call a family-friendly workplace in theory, and one size doesn't fit all. People can be asked or requested to agree to prospective cover, but you're under no obligation whatsoever. And it should not be imposed either. Leave entitlement is generally 6 weeks plus few additional days depending on seniority. The principle is that weeks are taken as complete weeks. I don't know whose principle that is. Certainly not mine. I take leave when I need to take leave for family needs, etc., etc. Leave isn't loaded to be all on. Well, unless that is what is agreed in the TEEB service planning meeting, that's not something we should try to enforce. Should generally be booked and to take into account the average working week, including the on-calls. That's fine. The principal figure used is actually 40 weeks, but if they want to use 42 weeks, that's okay. This actually, again, makes me feel quite annoyed. This is not how you show respect for very experienced and well-qualified colleagues. That's all I would say. It is reasonable to expect a fair allocation of leave amongst colleagues and also between DCC and SPA. But don't get me wrong, SPAs absolutely work. It's every bit as important as the DCC. Point 4, yeah, I would agree. No, if that had been asked in advance, and there is a policy for requesting payment for untaken leave, we can't really call that gaming. I don't even know what gaming means. Is the implication that this is fraudulent? Anyway, I better move on. Can't be good for my blood pressure. Yep, annualization. That's fair enough. We can't discriminate based on your specialty. If it works in one specialty, it should be made to work in every specialty, and vice versa. If it doesn't work in one, it doesn't work in other specialties either. The numbers are probably right. I don't know. This can be worked compressed to allow for days off. Okay. And this is the timetable. Again, you don't really, I would recommend that you do diary studies frequently. When you do a diary study, it should be for at least 2 rota cycles, and everybody should be really doing it at the same time, and ideally at different times of the year. Once done, it can be used for up to 3 years. Thank you.